Wow, wow, what a great start. Thank you, Dr. Williams. The positive comments are just overwhelming. And a shout out to our returning keynote speaker, Kay Johnson, for all the positive comments. So now it is my pleasure to move on to our next keynote presentation, Jennie Joseph. I'd like to introduce her to you. She is a well-respected advocate for women and babies. She is a British trained midwife. She has become one of the world's most respected midwives and authorities on women's health for healthy pregnancies, healthy deliveries, and healthy babies. She is also the founder and executive director of Common Sense Childbirth Incorporated and the creator of the JJ Way, which we will learn much about in a few minutes. This is an approach that she has designed for both women and children. She did move to us and joined us here in the United States in 1988 and began a journey that really has culminated in the formation of a very innovative maternal child healthcare system, which markedly improves the birth outcome of thousands of women and children. We are very pleased that she is joining us from Florida today, virtually, and I will now turn it over to my new colleague and friend, Jennie Joseph. Jennie?
Thank you. Thank you. Thank you. I appreciate the introduction. I appreciate the opportunity to be here today. I am just blown away and wonder if I could actually follow Dr. Williams. We'll see. What an inspiring talk. And I feel like that's the hashtag of all hashtags. It's time to tell the truth. Thank you, Dr. Williams. Let me get ready to share my screen. Just pulling up my slides here. So my topic today is operationalizing perinatal equity, quality, and safety in what I call the maternotoxic zones in the USA. And what I'm looking for, and what we're all looking for, is that every person, every time, has access to equity when it comes to perinatal health and outcomes. My organization is called Common Sense Childbirth. I want to share a little bit again today about what we do, how we do it. And I really feel like as we keep these conversations going, all of us will find ways that we can implement changes that are actually going to make a difference. So to state the obvious and to state what I consider the horrendous and egregious facts about maternal child health in the US, I've been here 32 years at this point, and we're still in the same situation. Our babies are dying. Our women are dying. There's no excuse at the end of the day. There is no excuse because the majority of these deaths are preventable. This is a picture of myself here. It was 2010. We were on Capitol Hill. I actually was working with Amnesty International at that time because they were the ones that I think started that real call to action around maternal health. They pointed out that there was a maternal health issue, but also that it was a human rights issue. We're still working, we're still striving, we're all on the same trajectory. But my hope is that we can get there quickly. As your questions came in for Dr. Williams, those are questions that, how do we get this done? How are we getting there? I feel like we may have some answers here. We may have some ways. So I want to engage you today to see if you agree with me. One of the stats I have on the screen here, I just want to go back to that real quick. Hold on. 50,000 nearly die or near miss events. That's worth talking about as well, because although it's horrible that we're losing every day women to childbirth, but we're also not losing the women, thank God, who survive, but barely. These are the people I am extremely concerned about, because as we know, women don't often speak about their experiences. They don't share their stories. They stuff everything down. They go back to work. We don't even have maternity leave, paternity leave, family support for postpartum mothers in this country. We're in a big mess. So yes, it's horrendous that 3 to 4 times as many Black women are being lost as white inside of this already awful statistic. But let's look at the near miss. The quote sometimes is 50,000. I've seen 60,000. I'm here to say it's probably hundreds of thousands, because if you survive, you're not a statistic. If you manage to make it out of the ICU after you've had a baby, you're not counted. If you have a postpartum morbidity or mortality, who's even talking about that? We may never be able to actually capture the numbers. So, for a little background on me, I'm a midwife. I started my training in 1979 in London. I was born and raised and educated in England. My parents are from Barbados in the West Indies, and they emigrated in the 1950s to the UK. And then I came across the Disney and fell in love with an American and came back. Disney stars in my eyes. I was coming back to be, part of the American dream. I was already a midwife at that point. I'd been in midwifery for 10 years. I get off the plane. I'm like, let me go get a job. That didn't quite work out. I am not a nurse midwife. I'm a British trained midwife, a direct entry midwife, as we call them now. Midwifery is a standalone profession around most of the rest of the world. So I'm in Orlando now, and I'm working and have been working in Orlando since I arrived. But it's been a difficult journey to be able to be the midwife that I was trained to be and to be considered part of the system here and collaboratively involved and engaged in what we all are about, which is saving lives. These pictures, some of the pictures in the slideshow are pictures from my book. We made a coffee table book back in the 2000s. I took pictures of women and families from the practice. We just wanted to highlight positive images of Black women. At the time, we found no other option, no other place where you could see positive pictures of birth, of family, of Black people. And so these are some of those pictures. But I put this one up here because we really, all of us, want to figure out, how can we center the patients? How can we center the family? It's not just that in not being able to center them that they suffer, they may even die. It's also that their loved ones suffer, their families suffer, their communities suffer. And I want to talk a little bit today about how we as providers also suffer. And I'm going to say the health systems themselves suffer. It's a ripple effect. So I want to tell a little story. This here picture is of one of my clients. So in Orlando, I have a birth center, freestanding birth center. I have easy access clinics, which are outpatient prenatal and postpartum care clinics for people who choose delivery at hospitals, even though I'm a midwife. I don't deliver in the hospital, I deliver in the birthing center. And so this mother here, you can see, you can kind of get an idea. She's obviously in the labor and delivery. We have made the transfer from the birth center in this case because this woman had a bit of an issue with her second stage of labor. She was trying to push this baby down. She wasn't making any progress. She got to a point where we were a little concerned. It had been a couple of hours and we weren't there yet. And I said, you know what, we're going to go in. I'm so blessed because after all these years working in Orlando, I've managed to create really strong and firm collaborative agreements. And we were well received at the hospital. As you can see in the picture, the nurse is smiling. I'm still able to stay with the mom and support her. I now changed my role into doula because I'm not privileged at the hospital. But you can see mama's okay. She's got a little oxygen on, which is helping her. She's got the monitor on her belly. She's just been admitted. And we're here because we need a little help to finish out this birth. So the physician on call came into the room. We were well received. I gave the transfer information. I gave him the history and report. The husband was engaged and was able to stay by the bedside. And even though you can't really tell under that towel, there's a big old heffalump child that came out of this woman. 10 pounds of baby was born vaginally. And just looking at that mother's face, I know you can tell the relief, the sense of accomplishment, the triumph that happened here in the fact that this woman was able to get this baby vaginally, safely, and was received well and treated with much respect and dignity. You can also see me grinning because I was kind of pleased as well. Every time we get that happen, I'm thrilled. So let me just explain a little bit when I'm talking about maternotoxicity, or what I call maternotoxic zones or environments, what I'm really talking about, because it's relevant to the story. So the phrase that I coined was just my way that I could describe what happens when a mother-baby pair, or a mother-baby family is surrounded by an atmosphere that is not safe. that is surrounded in a way that has them now exposed to harm that can be literally toxic. And so when we think about that, another way to look at it would be, if you yourself or your family, you wouldn't want them to be in those shoes at that exact moment. You wouldn't want to exchange places with that person in that situation. If you could conjure up what that feels like, that's what maternal toxicity feels like. Okay. The experience of it is that you are compromised in some way. You don't feel safe in some way. So maternal toxicity can literally pop up. So let's be clear, because we've talked a lot over these last decades about social determinants of health. And of course, Dr. Williams did as well. And we go straight to environmentally toxic, sorry, I'm moving ahead too fast for myself. The buildings, the neighborhoods, the zip codes, anywhere where, if your GPS takes you the wrong way, oops, I need to get out of here. That, in terms of the, what we usually jump to when we think about social determinants, is also part of what we are thinking about. But in actuality, there's the pop-up toxicity, which is equally as harmful, equally as impactful to the mother-baby pair. So let me tell you about this young lady, because this one is another interesting story about, again, a transfer into the hospital environment. This mother was attending one of my clinics. We run clinics for people who want maternity care, midwifery care, supportive care, culturally safe care, but are going to have a hospital birth by design and are going to be comfortable and happy to be delivered by the physicians or the nurse midwives who are on call for births at the hospital. So this young lady was in the clinic. She was waiting her turn and she kept pulling funny faces. She looked all uncomfortable. She kind of looked miserable. And I thought she was just mad because she had to wait. When we got her into the exam room, I went ahead and checked her. She was 8 centimeters dilated. So you can only imagine. So we realized, oops, that's why she's looking that way. She was like, Miss Jennie, I couldn't sleep all night. I didn't know what was going on. Well, what was going on was she was in labor. So at that point, we said, well, we need to get you over to the hospital because that was the planned place of birth. And the hospital always expect my patients, we have a collaborative arrangement that they can show up in labor and they will deliver them. So because she was 8, this was her second baby, my thought was, you know what, I'm not going to put her in this ambulance on her own because this baby might be born. And sure enough, the minute we got in the ambulance, we took off, boom, baby was out. So you can see in the first picture, literally the child is just born. I've got the baby skin to skin with mother. You can see by her face that she's totally bewildered. Like, what happened? Like, I just came from my appointment and I'm a mother once again. So that was her as we were en route to the hospital. The second picture is we actually arrived and we're getting settled in the triage. You can see now how beautiful this baby looks. Look how pink, look how healthy. The baby is rooting on the mother's chest. Babies typically left alone will find their way to the nipple and begin to establish breastfeeding. Also, though, I want you to look at her face. That same look, the newly delivered mother will generally, when she settles, that face, that speaks volumes. The relationship, the beginning of the bonding begins to take place. Now, this would make sense if you were in an environment where she had already been, in the labor and delivery room, for example, or if she was choosing a birth center birth, she would have been in the birthing room and nothing would have ensued here other than, guess what? The placenta would have been born and all would have been well. We would have said, congratulations all around. What a great experience. But she was in the triage department. And the response that she had was that, oh my gosh, this baby was born in the ambulance. And there was this sort of unreal kind of sense of panic and drama because the baby was born in the ambulance. And this is not to cast any aspersions on the staff or the team. Everybody was doing their job. Everybody was on point. But it looks like normal behavior in triage departments and even in labor and delivery rooms is there's a lot of running around. There's a lot of chicken with heads cut off kind of behavior. And the big problem or situation that ensued here was that there was a concern and a little bit of an argument, I'll be honest, about who was going to deliver the placenta. Should the residents do it? Should the hospitalists do it? Should the nurse midwife? There was a big old circus. about who should deliver the placenta. Anyway, it was resolved, everything settled, and they decided to take mother upstairs to labor and delivery. At this point, I'm ready to go because I feel like my job is done. Child was delivered safely, everybody's healthy, mother is smiling, placenta is born. So I left. Here's where the story goes south. This woman, as she was transferred upstairs, she told the staff she was planning to breastfeed. She had breastfed her first baby. We see the baby was ready to breastfeed. There was no reason to do anything other than allow this child to continue through the golden hour of bonding and connecting with its mother. But the nurse determined that the child needed to have a bottle because she decided that because the baby was born in an ambulance, it was compromised. She duly took the baby from the mother and bottle fed the child in the labor and delivery. The mother lost all agency and power. She was not able to ever establish a breastfeeding relationship with this baby. And so that is what I'm talking about when I say maternal toxicity pops up. I also want you to consider the other mother that I talked about and how she was received and how things went for her. Night and day different in the fact that once the system took over, she was continually supported, respected, and enabled through the rest of her experience. This woman, and it may be because of her color, it may be because of her race, it may be because the nurse was having a bad day. It doesn't matter, because at the end of the day, that child did not get its opportunity to have a breastfeeding relationship, which we know is protective for our babies. So I'm just showing you a little bit of some of the data that's been out there recently. 1 in 6 women experience mistreatment during childbirth in the United States. We're not talking about overseas. People of color experience more mistreatment in birth, led by the indigenous people, Latinas, and then Black, and then finally white. But that number, this is a quantitative number now, 1 in 6 in American hospitals. So again, I'm not sharing this to wag a finger in people's face and say, yes, you're bad and wrong, and that's why people are suffering or dying. No, I'm pointing out that we have systemic issues that none of us independently can address, yet we must begin to look at how do we dismantle systems that in and of themselves cause harm, that cause address and add to these social determinants of health. And here's the part that's quite horrendous. It's not just mistreatment in a sort of general subtle way, the microaggressions, for example. No, shouted at in a labor and delivery room in the United States, refusing requests for help, violation of physical privacy, threatening to withhold treatment. These are the top 4 of many types of mistreatment going on in the United States as far as healthcare. Here's the thing. Whenever we talk about maternal child health, we do tend to focus right in on the labor and delivery experience. And of course, what I've been talking about right now so far is labor and delivery. But most of this work and most of this need is in the outpatient space, in the pregnancy space, and for sure in the postpartum. Finally, we're talking about the need for help and support throughout the postpartum year. Yes, we must talk about that, because this is the only country in the entire world where we have totally ignored postpartum for the most part. A 6-week checkup doesn't do anything for anybody. So we have enough research. We have all the evidence we need. My question is, where is the evidence-based outrage? Where is that concern? Because at the end of the day, we have to ask ourselves, how much more can we keep gathering of these statistics and still come back with, well, we don't know, we need more research? Actually, I don't think so. We have plenty of information. And when we look at the evidence points to, this is about racism, not race. This is about classism. This is about sexism. This is about gender discrimination. This is about othering. And maternal toxicity shows up in those spaces. And all of us can be guardians of that. All of us can look at ways that we can mitigate that. Because if we start on the personal level, just like we do for our families, for our loved ones, for our neighbors and our friends, we can make a difference. My esteemed colleague, Dr. Monica McLemore, she wrote about this, among many other things that she says, but I feel like this is so pertinent because I believe this is the truth. Literally, to prevent women from dying, let's stop blaming them. Preventable morbidity and mortality is what we're talking about. So back to maternal toxicity. Okay, the maternotoxic zone can be lethal. It does lead to an increase in morbidity and mortality, and it continues to widen the racial disparities. But let's talk about the providers. The nurse that I spoke about in my illustration, again, not to say, well, look at this bad and horrendous person. She's so mean. She's so ugly. No, because we don't know. It may be that she's just accustomed to the system that says, baby's born in, outside of hospital or in jeopardy, baby needs feeding. The baby the blood sugar wasn't checked. The baby didn't look or continue to have any reason. It wasn't having any struggles. And yet her decision was to give the baby a bottle. She also went against the mother's wishes in doing such. So there's times when that work and that position as a provider, because you feel maybe helpless, because you don't want to buck the system, you certainly don't want to be fired or written up, that might impede your ability to do what you might want to do or what you might feel is, more expedient, safer. So there's an impact on the providers too when things like maternal toxicity show up. Many of us are suffering vicarious trauma, moral injury, a sense of helplessness and powerlessness because we're inside of this system, because it is the historical and the traditional and the, dare I say it, okay, I'm going to just use the word unjust policies and procedures that we still have in place to this day that may have continued on from times when maybe we thought those were great ideas, or we thought that way of being was acceptable, and it is no longer. But the impact on providers who are interested in the change, who want to see something happen here differently, who want to literally save lives, we're in a bit of a conundrum. Because if the solution to these problems is providing respectful care, and I'm here to say that is simply one of the easiest, most cost-effective solutions we could come up with. Treat folk the way you want to be treated, the golden rule. That has made the difference, and I'm going to explain to you how and why we've managed to figure that out on our end. So the JJ Way is the name of the model I came up with. I just was really stuck for a name, and I'm, sad for me. I created this silly name all these years ago, and it's stuck. So, I'm Jennie Joseph, and we've gone ahead and just held on to the name. But the mission of this work is to inspire change in maternal child health care, but also to re-empower the birthing mother, father, family, and community. And to do that by supporting the providers, the practitioners, and the agencies that are charged with their care. We will need to support each other. We will need to be brave. We will need to be bold as we look at how can we improve our systems? How can we implement changes within our systems such that every person who wants a healthy baby can get there? Every person, every time. The 4 ways that we've done this, the cornerstones of our work, is that these 4 tenets of access, connections, knowledge, and empowerment. The other thing that we've done is we've been able to grow this work and to share this work on a national level now. We have folk who are in congruence and believe what we're talking about and are doing the same thing. It's amazing how many people are on the ground doing their work. And so our national work, we call it the National Perinatal Task Force. We have now been engaging and enrolling folk who are doing similar work. So we have a community of practice across this nation where we can support each other, because we have to support each other to get these changes done. This is actually a movement. We consider we're building a movement to birth a more just and loving world. We feel like this is one access that we have. We have access to power through the love, the compassion, the care, and the respect that because we're independent, we're able to provide. And also because we recognize where the real issues are, we're willing and hoping and working hard to engage and support all of our interdisciplinary players in the perinatal field. So what we think we're doing and what we hope that we're achieving is investing in the community and the birth infrastructure in order to win all around, that everybody goes together to win. So the critical focus points that we have: safety, obviously, job one; quality, and developing a workforce to fill this space, to build out the ecosystem, to build out the infrastructure that we see is essential to the change. Okay, so this model is really about providing quality by utilizing people who to now may be overlooked, or people who are considered to be not part of the process, right? Like the outside of hospitals or institutions, those folk. It was so thrilling to hear Dr. Williams talk about how community members are getting access to the training and certification that they need, that they start the pipeline early, and they are community-minded folk who are going to return to support their communities. This is what we're about too. We want to provide the access for them. We want to provide the connections, the training, and the empowerment to be in the workforce. But also we want that the families have access to this quality care and support, that it's culturally safe and congruent, that we know that the stakeholders, the providers, everybody understands this from a safety perspective. And when we know that there are proven best practices and solutions that work, that can help Black and Indigenous people of color specifically, because they are the ones suffering most. But when we help them, we help everybody. So the quality needs to show up. The quality needs to be supported. The quality needs to be fought for. We must stand strong with that, that if we build in financial supports, if we create strategic partnerships, if we bring strong collaborative protocols to the table, engaging and supporting each other, now that disciplinary workforce can solve this problem. So this is how we work in our work in the larger picture, but let me tell you a little bit more about how we do it on the smaller scale. So this picture is from some of our clinic staff here. From left to right, I have June, who is a community educator. She's a perinatal supporter. She does a lot of our outreach work. She's a doula, childbirth educator, all-round lovely person. Everybody wants to talk to Miss June. Megan is currently a nurse practitioner. When she started with me, she came in as a birth assistant. She was 18 years old. She's now a registered nurse practitioner. She moved all the way through, and she has vast experience in hospitals and in the community. Katrina with the pink stethoscope, she came to me as a medical assistant. She's worked with us for 17 years at this point. Her community know and love her. Every family that's come through our clinics feels connected to her, and we all, we can depend on her. She knows everything that needs to be known about how we run a clinical practice. And then Alexis is another medical assistant on the end there, and she's been with us as well throughout the time, even featured in the book I mentioned. She had twins at a young age, and there are pictures of her and her twins in the book, in the coffee table book. But what we know is that we can grow a pipeline, and we can diversify the obstetric and perinatal workforce, which is what is needed to build safety, to build quality, to build cultural congruence. And we also know that by building our own from the workforce, from the community, we are making sure we acknowledge what they too need support for, because to me, we're all of us we really do better with trauma-informed care, trauma-informed support. It is traumatizing, particularly if you are from marginalized communities. where you haven't received that kind of care yourself. You haven't been able to have that support in the system yourself. So if we look globally, we don't have any problem in understanding the rights of childbearing women and understanding the power, for example, of dignity and respect, the freedom from discrimination. We understand safe motherhood, respect for her humanity. This is all work that we're doing overseas already and have done for decades and will continue to do because we're committed to that. So I'm asking us, how do we bring those same talents, tools, heart to the work we're doing for our own communities? And I know in Delaware, you are doing a specifically spectacular job of doing that already. And I'm so excited that I was invited today because it's so important to acknowledge when people are already active in the work. So again, we ask ourselves, is it about the culture? Is it about the environment? What is it that creates safety? Here's Issa measuring her mother's belly. She was always in charge of the tape measure every time she came to our clinic. So it was just easier to give it up and let her get on with it because she was in charge, but our safety comes in many different ways. And it's really about simple things. It's about things that don't cost money. It's about listening. It's about being present. It's about being compassionate. It's about recognizing with humility where privilege may show up and where it is not always the best choice to, for example, take a newly born healthy infant and bottle feed it against the wishes of its mother who wants the opportunity to breastfeed. These are the kinds of things that we found over the years have been really impactful in changing the outcomes. So let me share. I have some graphs here. This is when we first began to capture our own data back in the mid-2000s. Again, I'm in Orange County, Florida, Central Florida area. And so the first study we ran, we enrolled 100 women prospectively into the study. These were women from the Easy Access Clinic. They were not midwifery candidates, or they had not chosen a midwifery birth center birth. Rather, they were coming to our outpatient clinic for prenatal care. We also run clinics in Spanish. We use native speakers only, and we at one point had a Portuguese language clinic going as well, which we don't have any longer because we don't have a provider who speaks Portuguese right now. But when we were running our clinics back in 2006, we enrolled 100 women just to see what would happen. And look what happened. The year that we compared our outcomes to the Orange County and Florida outcomes, 2006, 2007, that year, more or less 20% of the Black women were experiencing prematurity. 1 in 5, 20%. And in the Latina case, about 15% were experiencing prematurity. But in our study, of the 100 women, not one, neither Black or Latina, had a premature baby. Again, consider what I'm saying here. These are people who are choosing to come to a community clinic. And I'll be honest, the reason that they choose our clinic is not because they're looking for midwifery. Some of them are, but not the majority. They choose our clinic because they know our policy, which is no one turned away. There isn't any barrier. Access is our first tenet. So we do not impede access for any reason. Rather, we run the triage. We make sure that we get you in so we can sit you down, so we can take a minute to listen and understand what it is you need, what you're looking for, what concerns you, and then we can work together to help you. There are many women who come into my Easy Access clinics who don't belong because they have high risks. And so because we run the clinic, because we give them access and allow them to get started, we can create a chart. We can order labs, we can order ultrasounds. And that is the access point for them to get to the maternal fetal medicine. You can't just show up at the maternal fetal medicine clinic and say, I know I have diabetes and I'm pregnant, can I get an appointment? No, you have to be referred to MFM. You have to be referred to high-risk perinatology clinics. You cannot be referred if you don't have a physician or you don't have a clinic. You can't create your own records. And sadly, if you run to the emergency room, you can't even get the records out of the emergency room because they get locked up into medical records. And until a physician requests them, you're not going to get them. So when you look at the barriers and the hoops and hurdles, the bureaucracy and the crazy, these are things that the system has created. And yet we blame the mothers. Oh, she's late to care. She doesn't care about her baby. She just ran to the ER so she could get an ultrasound. We have to be careful as we continue the tropes and the discrimination that shows up in how we perceive people are being and how we have a propensity to lean towards, well, it's their fault. You know, these women. So in our 2006 study, we came back with a 0% for Black and Hispanic. We had 4.7% of the white clients who did have a premature baby. Interestingly, all of them in that group were smokers. But of our white clients, and we have a cultural mix of clients, the majority of them who come to us come because they can't find any other provider. They come from a place of, I've been everywhere, no one else will take me, will you take me? Or no one accepts this Medicaid that I have and I don't know what to do about it. And so it's an interesting fact when we look at how this country is racialized and how things are operating on a racial basis, that, you know, it was the white women who had the premature births in our program. Same with low birth weight. So what we did essentially in 2007 with this first study that we did, we eliminated the disparity. The other thing that was really worth relaying to you is that these babies were chunky. We didn't have any skinny babies. Even those that were term, average weight was 7'7". And the average person delivered at 39 weeks. We were thrilled. So the access is key, like I say. The connections, though, is the next one. The connection is what bonds and keeps folk feeling safe. That's where the trust shows up. That's where the ability to disclose, to be compliant, to join in because you're invited in, you're treated with respect and dignity, and you recognize that what you have to say matters. And so we always go from step one to step two. If a family doesn't trust, if a mother doesn't trust, they're not coming back. If they're not coming back, they're in more jeopardy for a poor outcome. So the connection was an important part of the model. Once we connect, once we feel that there's a listening ear, that we're listening to them, but they're in turn are listening to us, now we start imparting knowledge. This is when you can get across some of the education, and this is where health literacy can be mitigated. If folk don't have the information they need, they can't do their part. But they're not always going to receive information in the ways that we want to give it. So knowledge exchange is how we get this information across. We need to learn how they want to learn. And then in turn, they let us know what they need us to know in order to help take care of them better. But here's number 4, empowerment. Everybody wins. Everybody wins. We as a staff feel better. We are more engaged in our work. We're more excited about our work. You see the longevity in our work. You know, I have staff that's been with me forever, but also the families feel stronger, feel better. How is it that somehow this kind of approach causes services to lock tight? How is it that the child's birth weight is increased because of this kind of care? We aren't doing any fancy or expensive obstetric wizardry. We're not shooting everybody up with McKenna injections so that they can go to term. This simple approach has made the difference consistently. So in 2014, one of the studies we did a comparison and matched pairs with a local demographic, with a clinic that had also been providing prenatal care, because we wanted to see, was it just the actual prenatal piece, the medical care, because there are studies that look at quality of prenatal care or numbers of prenatal visits, and they call that adequate or inadequate prenatal care. So we did a match study in this case, and we came out statistically significant for the mix, the same demographics, the same mix of race and socioeconomic status, and the fact that both groups were receiving prenatal care. But our group, once again, longer gestational periods, lower preterm birth rates. This is significant because, again, what's the intervention? Well, if you want to say in a nutshell, being nice, being compassionate, being thoughtful, being respectful. The 2017 study was also quite an eye-opener. At this point, when we got to this one, we had a higher preterm rate in the 2017 at 8.6, but we were still lower than the county and the state. And also for Black women especially, we were way lower. And then what was interesting for us was that the white women also were lower than the white women in the county and the state. This has been our consistent experience year in and year out. The COVID year, 2020, we went to telehealth completely. We shut down our clinics. We were still delivering babies as they showed up in labor, but we did all prenatal care and all postpartum care via telehealth. We were mailing out Dopplers. We found a bunch of Dopplers on eBay, and we would buy the Dopplers that we could afford. We did donation drives, and we provided mothers and families with Dopplers at home so they could hear the heartbeat. They had blood pressure cuffs at home. I started sending out urine test strips so they could pee on a stick at home. We were as creative as we could be. But what we held was that there was still access to the safety and quality of our care. And so through the COVID year, we came back with one premature baby out of 486 patients for that year. So again, we find ways anyway, whether it's in the waiting room, as you see here, to provide the access, the connections, knowledge, and empowerment. We did it over the phone. We did it over the video cameras. We did it anyway and anyhow we could, and we still got to the outcome. So we're looking at these common sense solutions. We're asking ourselves, because common sense childbirth, that's my name, that's what we do. We have got some opportunity here without spending a holy fortune to be able to tweak this. And like we say with the National Perinatal Task Force, to birth a more just and loving world by centering ourselves, interestingly, in order to center the patients, the clients, if that makes sense. So one of the ways we've done that is we've engaged and embraced the community, which is its own best resource. The community, which is often overlooked, other than when it's time to do more research or to get more grants funded, but the community has its own answers. And so we look to the community to see who's already there, who's already willing, who's looking for support, who wants to be trained, who wants to join in. And we know that the community-based practices, the community-owned, community-led providers who are out there are on the ground anyway. Whether we help them, whether we compensate them, whether we recognize them, whether we collaborate with them, they're already there. They're already in action. I'm talking about the doulas, the lactation providers, the community health workers, the medical assistants. How many OB practices are run by medical assistants? That is how we do it these days. The medical assistants are an absolute wealth of lived experience. And of course, the community nurses and the community midwives are out there too. These solutions are right there. They're not even expensive, but they are protective in every materno-toxic zone or situation that our families find themselves in. We are willing to get in and join in and become members of a team that has the same goal, which is safe outcomes for every mother, every baby, every time. We already provide quality care. We already provide culturally safe care. We meet women and families where they are, and we know how to do that. And I believe, again, we can bring these qualities to the workforce and work with an interdisciplinary and collaborative teams. We can actually eradicate these statistics as well. So what do we need? Well, we need access. All of us need access, not just the patients. But our patients need access to safe, quality maternity care, to the appropriate level providers, because in the inability to move folk through the levels, we end up with the morbidity and the mortality. And the levels need to include not only the labor and delivery aspect of levels, but also the prenatal and the postpartum, essentially the perinatal levels of care, with the appropriate providers who can act with cultural humility and the willingness to acknowledge the truth about what's going on. If we can set those levels up, if we can support those levels, we have solved the problem. We need access then to the sites that provide all those levels of care. And that does include home birth, just like it includes home visits prenatally and home visits postpartally. That does include birth center birth and an access to birth center care prenatally and birth center care postpartally. It includes hospital birth. This is not a conversation about hospitals are bad and wrong, or we don't want to do anything with them or burn them all down. No, this is about, let's make sure every person, every time, that there's access to hospitals and institutions where the levels of care are appropriate, where they're safe, where they are congruent with everybody's humanity. So back to the providers then, because we have some issues. We have access issues ourselves, because until we understand the inbuilt and the historical and structural harms of this disconnected and broken system, these unwieldy ways of doing business, because we are in business, it's a medical business, until we understand what we're really working in and with and for, we can't do anything about it. We also need access to the training, and it's not just implicit bias training that I'm talking about, because that's helpful, but that's not the overarching. What we need is how to be able inside of our work to have support and empowerment to be able to, when it's necessary, individualize care. Think about the situations. If we had had time inside of a system to break down the fact that once you get swept up into it, you may not have the best result. We wouldn't have had the situation that I described earlier, the young lady who was denied her opportunity and her baby was denied the opportunity to be sustained with mother's milk. If we had had some support and training around, let's stop a minute, all stand back and take a breath. Let's look at what we have here and individualize the best for this mother-baby pair every time. That wouldn't have happened. And of course, the students need access. They need access to scholarships, to grants, to loans for training. They need to have access to, sustainable work. So when they finish these trainings, these certificate programs and these pipeline programs, that they can actually live on the wage that they may earn, or that they may be supported in whether it's grants and funds, but they are recognized as contributors to this perinatal ecosystem that we so badly need in this country. And when you do these things, this is what you get. I want you just to take a minute and just look at these mothers. This is a group of our postpartum moms at the Easy Access Clinic. And if you see these babies, look at the thighs. Do you see the rolls? These are breastfed, happy babies. Moms obviously doing really well and thriving, supporting each other, meeting and joining the group so that they can all share and have their experiences. We know that these outcomes have been consistent since we've put our programs in place. And as I said, we are scaling. We have replication models. We have easy access clinics in Dallas. We have in Columbus, Ohio, Minneapolis, you name it. It's growing exponentially. Folk who are doing work the same way that we do it, that they're owning that community space, that they are building out that community space, because the work that is necessary is in the community space. My appeal today is that as you grow and move forward in your amazing work that you're already doing in Delaware, that you consider perhaps here's another angle to look at as we move forward. So I'm going to wrap up here so we can take some questions. Let me stop sharing. See if I can get back. I'm back. All right.
Right.
Yes, thank you for having me. It's really great to be here today. I hope there's some questions I can answer.
Of course. So on behalf of all of us on DHMIC and all the listeners, thank you for such a strong and insightful and really just really authentic presentation. So thank you so much, Jennie. All right. Well, for questions, let me just, I hopped over to the comment section and I can view them. So let me just say that a lot of the questions you had for Representative Minor Brown, that will occur later when she speaks at 11 o'clock. Oh, you guys are a little quick for me there. One of the questions that we wanted to highlight that came out, and we know we love the every person, every time. Here in Delaware, we had a program that we were starting to a paradigm of every woman, every time. And April Lyons-Alls was our consultant that had worked on that for us. Same idea is that every individual, it matters every time, at every encounter, at every opportunity. It is really, really important. So we really appreciate you bringing that out. We also, there was many comments about your access, connection, so important, and then the knowledge and empowerment.
Yes.
One of the things is people were trying to think, can we do this in Delaware? And you said that it was in Minneapolis, Columbus, Dallas. But what are some of the barriers for replicating your model in other communities?
Honestly, there are not so many barriers. It's just, I think we have this overall perception that there are barriers. There can't possibly be any barriers. Even Dr. Williams said, there's no shortage of money. So it's not that, right? I think it's really us being willing, as especially larger institutions and larger payers, funders, to recognize the community workforce that is already there, and due to their lack of ability to access those funds, to be supported in that funding, that they in turn have a hard time. All of us are doing it from the entrepreneurial perspective. We're figuring it out on our own. We're figuring it out when we're doing, so much of this is uncompensated care. To do no one turned away, we're doing uncompensated care. So the barriers technically are rather from the provider place, in that it's a struggle to get a clinic up and running when you don't have funds, or if you have funds for a year and then they're gone, right? This is where it shows up. So it's about, again, infrastructure. So we are also building our own fund at Common Sense Childbirth to invest in community birth infrastructure. So it's not about saying, well, everybody should have a home birth and everybody should have a midwife. Those that choose that, we're right there, we'll support. But it's about saying that midwives, nurse practitioners, mid-level providers, community health workers can run community-based practices, provide perinatal outpatient care, and the hospitals still deliver the babies. So there's a barrier there in terms of thinking that that's doable or even desired. There's a little territorialism that shows up. There's a little interdisciplinary that shows up, right? We are on our way. We are making strides, But I think the barriers, most of all, are in our heads. When it came down to COVID and we had to scramble and get it together, money showed up, thought processes changed, creativity was present, and we got a lot of things achieved during COVID that we wouldn't have done if we didn't have a pandemic. It wasn't perfect, but we at least were in action. What's missing in this work is that we are still a little reluctant to be in action. I don't know how we cannot be, given the outcomes that we get with these actions. They're stellar. We're not dropping it by a point here and a point there. The same COVID year, where every other person was getting cut, we had a 17% cesarean rate for the mothers in the Easy Access Clinic. And these are people who had chosen hospital birth as a matter of course. Their co-peers were getting the same C-section rate that everybody else gets, but we are the lowest C-section rate in the city. And we're not even in the hospital doing the actual labor and delivery episode. So
amazing.
Yeah.
Thank you. Thank you. The barrier is our will.
Yes.
Our will. We have to have the will to do it. So thank you. Thank you.
you.
The other thing is that postpartum period. Many of us had conversations within the state of Delaware that it's an open door. There's so much that could be done in that year postpartum. But as women have told us that we only care about the wrapper. And once the baby is born, we forget about her. And it's such a time to have such innovation and such creativity. The door is wide open.
Yes.
First, we know that we want to get women in sooner. 2 weeks would be great. High risk even sooner with the standards that exist. But what are some of the opportunities, some of the things that you have done there in that postpartum period that you'd want to share, or that you've seen other states or partners do?
Oh, I mean, it's just amazing right now. And I think, when you said, the candy wrapper as a great analogy, and you said the women have told us, yes, because the women keep telling us they share exactly what they need. And so what we've always done, and we've now, since this legislation is going around the country and more states are opening up the postpartum year for Medicaid, what we've said is that the people that provide those services already exist. We just need them to be recognized and incorporated into the fee schedules so that they can earn a living while they do their work. So I'm talking about community health workers. We train maternal child health community health workers to do postpartum care. Doulas also do postpartum care. Childbirth educators and lactation supporters do postpartum care. The workforce is there. We now need to find equitable ways so they also get the every person every time. They get reimbursement, acknowledgement. These people have NPI numbers. They have Medicaid numbers in many cases, but it's, we only reimburse through the physician or through the health departments. We have to be creative. And so we've been doing this on the ground work, mostly through telehealth. This was before the pandemic. But postpartum mothers are grateful for a phone call every couple of weeks. When they're back in the workforce and they have issues trying to figure out how to pump at work, no one's there. Yet we provide that continual connection that keeps them with us way past the year. Most of them go right through to the next baby or the kids doing kindergarten, but we are family and we are staying connected. And in that support, again, not only the mother-baby family, but the providers also feel so fulfilled in the work that they're able to do. And let's be honest, no one else in the spectrum of providers, perinatal providers, is really going to do much in that postpartum space. And the other thing we've been able to do is support the behavioral health aspect of postpartum. That check-in phone call is a lifesaver. And in the dearth of postpartum behavioral health support, especially for our Medicaid clients, that has become a big problem. So as we see this developing, we're thrilled that Medicaid hopefully will expand into behavioral health as well, because that's a tremendous need. Much of the postpartum morbidity is about mental health.
What a way to close us out. That is something that we've identified here in Delaware, and we're working with different work committees within Well Women Committee and Black Maternal Health. We have some new partners that have come to the table. And really that was addressed last week in the Black Maternal Health Awareness Week webinar, just really creative ways in how we need to do a better job looking at the whole woman, physical, mental, emotional, and meeting her where she's at.
Yes.
One of our colleagues, Kay Johnson, just put in the chat that we need to provide, if I can quote her, quality, culturally congruent perinatal care, meeting women where they are physically, emotionally, financially, and mentally. And
Yes.
I think you would
Yes.
agree. I think
Yes, I do.
well, I'll tell you, Jenny, we have waited a while for you to be able to come here. You've been on my list for several years. You have really, it's been a joy and treasure to have you with us today. And we plan to stay in contact. Some of the questions that did not get answered, I see it, and I'm going to keep Jenny on the screen with me. The rest of you all get to take a break till 11 o'clock. And any of the other questions not answered, we'll try to get back to you. And I want you to know that while you're at break, the screen that you saw of our graphic recorder, Rio Holiday, will be on, and you can see some of the work that she did from this session and possibly from Dr. Williams. And if not, you will see it later in the day. So take a break, do what you need to do, and we will start back promptly at 11 o'clock. And thank you, everyone, for joining us in this exciting morning, and more to come. And a lot of those Delaware-specific questions that you had in the chat, some of those will be addressed in the next session in the Black Maternal Health panel with our Delaware speakers, moderated by Dr. Paul. So thank you. And Jenny, thank you. We're going to stay in touch.
Thank you very much.
Thank you so much.
Bye-bye.
See you all soon.